Yes, now good.
Okay, yeah, thank you.
Yes.
Hello, good evening, everyone. Can you hear me okay? Hello, good evening, guys. Can you hear me okay?
Yes.
Okay, is the voice clear? Can you hear me clearly?
Yeah, we can hear you. Thank you.
Okay, okay, good. Fine, I think we'll start now. So my name is Mohammed. I work as a specialty doctor in Wales, and I'm one of the faculty for this course. So I hope you enjoyed the previous two sessions. I understand that you had some discussions about what's the exam like and what you expect from the exam. So I think we're not going to spend a lot of time on that. I think we'll just go ahead and start doing some cases. So the first case is a case of early rectal cancer. So this will be, I think, is suitable for one of the colorectal guys. So anyone want to volunteer and take this case first? Okay, fine. I'm happy to go ahead, Amy.
Yep. Hello.
Yeah, hi. So fine. So this first case is about a case of early rectal cancer. So you're doing a colonoscopy on a 50-year-old lady, and you find a small polyp, which is about 1 centimeter in diameter, at 7 centimeter from the anal vag.
Yep.
Can you see the image?
Yep. Yes.
Sorry. Oh, fine. So I'm just trying to see how we can scroll it down, which is not as easy as expected. Okay. Just give me a second, just see if I can scroll it down. Okay. If I go there. Okay, fine. I got it now. Okay. Okay, so this is the image that you see during colonoscopy. So how you are going to approach this case?
So so let me have some description about the imaging here first. It is a tumor as described by you is 7 cm from the anal verge, is 1 cm. I can see actually the it's quite fixed, and I cannot I can see the mucosa is a bit irregular, and also there is a deep central ulceration as well. Probably some component of invasion, maybe a cancer. And if possible, I also want to see the MBI images and also do a magnifying colonoscopy to see the PITS pattern as well. But I think for this lady, I will definitely take a focus history and also do a physical examination if I have the chance to see her. And
so you just doing a colonoscopy, and you find this lesion.
Yep.
So what are you going to do with the lesion?
So I would, as I said, in the colonoscopy, I would like to do the MBI and also the magnifying colonoscopy to see the pits pattern and the capillary pattern. And I would definitely need to take at least 6 biopsy from this lesion. And apart from that, I will complete the whole colonoscopy to see if there is any synchronous lesion. And I will also try to assess the location of the mass, because if I am thinking about some sort of local excision later on, then I possibly need to know the orientation of the tumor if possible.
Okay, excellent.
Yeah.
So you did the NBI, you did the magnification, and you think from what you've seen, it looks like more of a benign polyp rather than a malignant polyp. So this is what you think. So it's difficult to say. So as you can see, there is a central depression, which may be suggestive of invasion. But the NBI images, like you can see, there is maybe bit pattern type 3, and you are not sure if it is benign or malignant. So you said initially you will take 6 biopsies. Would you think about excising this polyp?
I would try to see if I can use some normal saline injection, if I can sort of like inject through the base, whether it is raised up or not. I mean the lesion, but according to this image, my impression is that it's quite fixed.
Okay, good.
Yeah.
So the decisions that you may need to make now, are you going to resect it, or are you going to take biopsies and not resect it?
I won't resect it now. During the endoscopy, I will take biopsy, and I will probably properly work up, do the workup for this lady as cancer pathway. Okay,
excellent. Okay, so this is what you did, but unfortunately, someone else was doing the colonoscopy, and what they did, they just decided to do ESD for the polyp, and they removed the polyp as a base meal. Okay, and then the histology came back later as invasive adenocarcinoma. And so you are seeing this patient in the clinic now, and you got this histology report showing invasive adenocarcinoma. So what other criteria that you would like to look at the histology report?
First of all, I would like to know the size and also the margin, whether there is enough margin, for example, whether margin is involved or not, and also whether it's lymphovascular invasion. And if possible, I want to see if there is any Kikuchi submucosal invasion classification in the report that is available. I think these are the risk factors that I need to take into the account to decide whether this patient need a further local resection or need a definitive like TME type of resection. Yeah.
Okay, brilliant. So we're looking at the high risk features. Okay, so this is what the histology report tells you. So it's just moderately to poorly differentiated adenocarcinoma. There is some focal lymphovascular invasion. Deep margin is positive for tumor cells, but they are not able to tell you any cohortial levels because of the destruction of the deep margin by the thermy. Circumferential margin is clear, and the total width of the tumor is about 1 centimeter, and the tumor is MS stable. So what next?
So since the pathology report say it is focal lymphovascular invasion with deep margin involved. Sorry, I can't see the small print, but I think it's really high risk factors with high lymph node mets, maybe more than 20% in this case. So in the clinic, I will discuss with this patient. First of all, take a focus history assess about some risk factors like family history and also her symptoms, and also assess the performance status. And I will also do a physical examination just to make sure there is no palpable mass. And I'm not quite sure whether the PL can feel the mass, and also see if there is any bleeding. And after that, I will have a proper workup for her and disclose the information to her.
Okay, so what
Yep.
workup you ought to do?
I will take bloods, including tumor markers, and also basic bloods like hemoglobin level, liver renal function test, staging CT, chest, abdomen, and pelvis with contrast, MRI pelvis. And I will also discuss this patient with the pathology report in the MDT as well.
Yeah, excellent. So you did a CT scan, chest, abdomen, pelvis, which is normal, no metastasis. You did MRI rectum, not MRI pelvis.
Yep.
Because you need to make sure that you say MRI rectum, because you don't do MRI pelvis, just pelvis for rectal cancer. So
Yep.
you did MRI rectal protocol, and some of your colleagues suggested that you may do as well endorectal ultrasound, but it's not necessary. Okay, so do you want to repeat an endoscopy or repeat rectal sigmoidoscopy or anything?
If the first colonoscopy is already complete, and
so remember,
yes,
this patient,
yeah,
remember, someone else did the colonoscopy, so you didn't do the colonoscopy yourself.
Yes,
so,
yes, I want to repeat it myself.
So you did a flexible sigmoidoscopy yourself.
Yep.
And this was the image.
Yep. So I can see there is ulceration from the previous ESD site. So I will also, if possible, I will also do a tattoo around that site, because my plan is I will do a TME, low anterior resection TME type operation for this patient if the CT has no mass and the MRI showed CRM negative. And I just
So do you normally tattoo cases of rectal cancer before surgery?
No, for if there is very obvious tumor in direct for all the CA rectum, but for this case, because it is just a scar.
Yeah.
So usually my practice is I won't do any tattoo for any CA rectum if there is a definite mass, but this is just a scar from the ESD. So I would maybe just put a tattoo next to the scar, just to direct me from the give me some direction during the surgery.
Okay, so what is the disadvantage of putting a tattoo in the rectum?
It will increase in some scarring during the dissection, especially the TME plane.
Yeah, so exactly. So the problem with the tattoos in rectal cancer is some of these tattoos can spread out of the rectum, and they can stain the mesorectum, and they can cause a little bit of inflammatory reaction along the mesorectal plane, and makes the dissection a bit more difficult. And sometimes you're not able to identify the appropriate plane. So that's why it is not advised to tattoo rectal lesions.
Yep.
And instead, most people, what they do, either they do an intraoperative registry to assess the location of the tumor, or if they're going to do lab-assisted surgery, they would have a feel of the tumor by hands anyway.
Yep.
So as you said, you can argue that this is just the scarring of the tumor, and you may not be able to palpate it if you're going to do TME surgery. You can tattoo it, but it's as you said, there is this advantage of tattooing. So it's better if you avoid it, if you're able to know exactly where the tumor is.
Yep.
Okay, so fine. So you said we did the CT, chest, abdomen, pelvis. There was no metastasis. You did MRI of the rectum, and the MRI showed possibly there may be a T3B N0 tumor with negative CRM. This is your MRI scan. Okay, so what do you think the limitations of MRI scan in such case?
So if
after the
CRM,
bulbectomy.
so if CRM is negative, that means, and also a T3B lesion. I would actually, of course, I would discuss with the patient for all the options, but I guess I would, for my decision is actually I'll intend to go for a surgery because it's a CRM negative, not threatened. That means we may not need any like neoadjuvant therapy to downstage a tumor, and the risk of lymph node recurrence after the operation or local recurrence for CRM negative tumor is much lower than CRM positive tumor.
Okay, so it's important here just to be aware that in such cases, when you actually do bulbectomy and the histology comes back as cancer, MRI staging sometimes can be not accurate. And the reason for that is after bulbectomy, you would expect to be some kind of inflammatory reaction and edema. And this is why sometimes MRI scans can overstage the tumor. So you can see the MRI scan saying it is T3B tumor. But on the actuality, when you look at the flexible sigmoidoscopy that you did, you couldn't see any residual tumor at all. And this is why it's basically this is what the MRI does. So this is important just to be aware of the limitation of MRI in such a situation. For overstaging of tumor, as T3 can happen due to the fibrotic reaction or desmoplastic reaction that can happen from the bulbectomy action. Okay, so what we've done so far, we've done clinical staging. So and the clinical stage is likely you got a patient with potentially early rectal cancer with CRM negative and a potentially resectable tumor. But on the other hand as well, it has been endoscopically resected and you are not sure if there is any residual tumor or not. So the clinical stage, you may have a tumor which is T1 but with high risk features, as you mentioned previously. It may be a T2 tumor or maybe a T3 with negative CRM, and all of these are still in the vicinity of early rectal cancer, which can be cured by surgery. Okay, so what are your thoughts now? So what is the next step? So this is all the information that you have. So you've done clinical staging. You think it may be T1, T2 tumor, a CRM negative. There are no metastases. Okay, and you got a 51-year-old female in front of you. So what are you going to discuss with this patient, and what are your options?
So I would, of course, this case has to be discussed in the MDT. I think the options will be a direct surgery with a lab LAR and TME type of surgery, and a defunctioning ileostomy if necessary. And another option is a neoadjuvant chemo-RT with a watch and wait approach if possible. But my concern is that the pathology actually showed some worrying features, which is the margin is actually positive, and also there is some lymphovascular invasion as well. So I think the risk of lymph node mets in this case actually is higher than maybe 10%. So for my discussion with this patient, I would offer a surgery to her.
Okay, so
but of course I will discuss with the options. Yeah.
Okay, so let's go back to the MRI scan. So suppose that the MRI scan says it is N1 or T2 or N2 tumor. So you got a T3 tumor with N1 or N1 or N2. So will your decision will be different?
Yes, if it is N1 or N2, I'm more prone to refer this patient to oncologist for the discussion of neoadjuvant therapy first before the surgery. Yep.
Fine. So suppose that the oncologist tells you that this patient got a negative CRM on the MRI scan, and they can be cured by surgery. So sometimes the oncologist may not be, sometimes they may not accept to do neoadjuvant treatment for patients if they got a CRM negative, because they will argue that, okay, it's CRM negative. There isn't much that you're going to achieve from neoadjuvant treatment. Is it better to take the patient to surgery straight away, especially if they are N1? Let's say it's N1. So the only options that you'd have now is surgery. Because the other options, because all the other options, whether surveillance or palliative or adjuvant radiotherapy, wouldn't be appropriate, because this patient still need a curative operation in view of the N1 status.
Yes.
So if the MRI scan tells you that you got positive lymph nodes, then you don't have any other option apart from a TME operation to take these positive lymph nodes out with the tumor. Okay, but in this situation, you got a tumor that you think may or may not be completely excised, and N0 with no lymph nodes on the MRI scan. So you still got some option to discuss with the patient. So you got the option of transanal excision. Either do you do transanal minimal invasive surgery, or you go for chemoradiotherapy, or you consider maybe total neoadjuvant treatment, or just surveillance or observation, or obviously the TME surgery. So in a 51-year-old lady, so you said this is high-risk tumor. There is lymphovascular invasion. The margins, the deep margins, looks positive. So definitely there is something else need to be done. You chose to go to take the path of TME surgery.
Yes.
So what are you going to discuss with the patient about the TME surgery? So what are you going to offer to the patient, and what are the risks and complications that you are going to discuss with the patient?
Yep. I will discuss with her about this operation. I will go through the procedure, indication procedure, and the risk. And the reason for this definitive is a definitive operation for this disease, and also we will be able to clear the lymph nodes that we are uncertain about, and also to decide whether there is any lymph node mets. So for the risk of this operation, there are general or specific risks. Specifically for TME, I will tell them about the risk of anastomotic leakage, which can be up to 15 to 20%. And also there are risk of light injury to surrounding structures, including the ureteric injury, gonadal vessels, and also some pelvic nerves injury will cause sexual or urinary dysfunction. I will also tell them that because of the low anastomosis, there is high chance that there may be a defunctioning stoma. But one important thing, I will also assess the sphincter function of this lady. But I presume 50 years old, her sphincter function, if it is good, then the chance of like Hartmann's operation for her permanent stoma may not be high. So I would discuss with her that there is a high chance of like defunctioning ileostomy. There is also risk of stoma like obstruction, prolapse, retraction, stenosis, and obstruction and hernia in the future. And I will try to close the stoma for her later on, after all the treatment is completed. And other general complications for like wound infection, bleeding,
Yeah, okay. Yeah, fine. Let's focus on the surgery specific complications here. So when you mentioned sexual and urinary dysfunction to the patient, she wants to explore this a bit more. She asks you, what do you mean by urinary dysfunction? And what do you mean by sexual dysfunction?
So there are some lymph nodes, I would discuss with her with a drawing if possible, for the nerve actually around the inferior mesenteric artery. There are mainly the hypogastric plexus, that any injury will cause So I think is if she's a lady, then maybe there is some effect on the orgasm, or maybe it's vaginal dryness or something like that. And also there are some lymph nodes around the lateral pelvic region. They are parasympathetic nerves that during the dissection, if there is any injury, will also cause the bladder dysfunction, is the hypotonic bladder. And there are also inferior hypogastric nerve plexus.
Okay, yeah, fine. Just say, let me stop you. Yes, it's very important to know what are the specifics of urinary and sexual dysfunctions that are going to happen, because this is a very common question. It is very well explained in the cracking is a cracking. So the cracking book has explained this very well. I think there may be a quart, like maybe 3/4 of a page about this issue, just explaining it in details. What is a sympathetic nervous system injury would cause, and what's parasympathetic nervous system is going to cause. I think it's good to read it from there. Okay, fine. So you mentioned all of this to the patient, all these complications, and she asking you, fine, is there any other option? This surgery seems to be a major operation, and you told me that the tumor is small and it has been removed. Is there any other option?
Another option is a neoadjuvant chemo-RT, with a discussion with the oncologist, and try to see the tumor response, and we'll see if we can go through the watch and wait pathway. And I think transanal excision is not feasible for her case. The reason is not a T1 lesion, and also there is possibility of lymph node mets. So I don't think local excision is a good choice in her case. Yeah.
Okay. So when you discuss this case in the MDT, they said there is a possibility that the tumor may be T1. And the only problem with the tumor, as you said, there is high risk features and there is some invasion at the deep margin. So someone suggested that you can go ahead and do a completion resection and do a full thickness resection of the scar. Is this something that you would consider?
I don't think so, because I'm quite worried about the lymph node metastasis in this case, according to the first report. Yeah.
Okay, so remember, the first report didn't tell you anything about the Kochi staging, or the SM levels. So you don't know that. You don't know if it is SM1 or SM3, and you may be completely right. It may be, if it is SM3, you would have 21 to 23% possibility of lymph node metastasis. Remember that the MRI scan didn't show any. It was N0. So again, someone may argue, say, fine, the MRI scan is telling you that it is N0.
Well, these are the options that I can discuss with the patient.
So I think,
but
yeah,
I would think
it's very important here. In the exam, it's very important here that to say what you can do. So if someone tells you you can do TAMIS, if you say, I'm sorry, I can't do TAMIS, I don't know if I haven't done it before, and what I can do is a TME. And if the patient is willing to have TAMIS, then I may refer to the patient to a different colleague who can do TAMIS. So because in this case, all these options are possible. So you can do TAMIS, you can do TME, you can send the patient for a chemoradiotherapy or adjuvant radiotherapy. And you can just choose to survey the patient with flexible sigmoidoscopy every 2 to 3 months. So all these are possible options, because nothing right or wrong about them.
Okay.
Because it is uncertain whether the tumor is being completely excised or may have been completely excised. No one knows.
Yep.
So, and it's very important when you have a case in the exam with all of these options available, that you need to stick to what you know and what you can do comfortably. Okay, if you go ahead and say, I'm going to do TAMIS or offer TAMIS, then they will ask you, how are you going to do it?
Yeah.
Okay. And one other thing is, it's very important in these situations to fall back on the guidelines, the latest guidelines. So there are clear guidelines from the ACBGBI on early rectal cancer.
Yeah.
And they are very detailed, and they contain all the information that you need. So if you go and say, okay, I'm going to do TME surgery for this patient, because according to the ACBGBI guidelines, this is still the main standard of treatment for these cases. Okay, so no one will argue with you, because they will know, okay, it's fine. You know what our guidelines are, and you are sticking with the guidelines, and you are offering the patient the best standard of care. So the other options, if you look, for example, at chemoradiotherapy and TNT, if you look at the ACBGBI guidelines, so most of these options can be offered to some patients who are either not fit for surgery or they don't want to have surgery. But otherwise, if the patient is fit for surgery, so the standard of care will be TME, and the TNT or chemotherapy or chemoradiotherapy or the adjuvant radiotherapy will be only in clinical trials.
Okay. Sure.
Okay, fine. So one important thing as well that you need to discuss with the patient if you are going to do surgery, because it's you don't know if the tumor being completely excised, and you don't know if there is still residual tumor there. So it's very likely that you are going to do a TME surgery with all the risk and complications associated with the operation.
Yep.
Okay, and then the histology specimen comes back completely free of tumor. So you need to explain this clearly to the patient.
Yeah.
Okay, because suppose this patient, for example, had a complication from the surgery, either an anastomotic leak or died from the operation, and then the histology comes back as normal or negative for malignancy. The patient should be aware of that. Okay?
Yep.
Because this may change their opinion. This may change the option that they are going to choose when they decide what operations they're going to have. And remember, anterior resection or TME surgery carries a risk of about 5% mortality in 6 months in the UK, and about 30 to 40% morbidity in 30 days. So it's a comorbid operation. Okay, so all of these options need to be discussed with the patient. Fine. So will your decision be different if this is an 82-year-old gentleman, okay, with significant comorbidities?
Yes.
Okay, so why it is going to be different, and based on what?
It's based on the performance status of the patient. I think the patient may, of course, I will assess the 80-year-old gentleman, the performance status, but according to your information, it's multiple comorbidities. So he may not be able to tolerate a ultra major surgery like a TME. So I will still discuss all the options with him, but I would think TME may be too high risk for this patient. So maybe local excision, or if the patient is fit, because he has comorbidities, I'm not quite sure whether he's fit for adjuvant. Yeah, but then these are better options for him. Yeah.
Yeah, exactly. So TME may not be an option for comorbid patients. If the patient is fit for general anesthetic for a short operation like a TAMIS, you can offer the patient full thickness excision. Or if the patient is not fit, you can still consider adjuvant radiotherapy.
Yep.
But remember, it's very important as well to know, because with the organ preservation, so been lots of trials now on rectal preservation and early rectal cancer.
Yep.
And there have been a couple of American trials. I think they reported a few years ago that there is significant morbidity from radiotherapy and organ preservation. And you will see clearly in the ACBGBI guidelines that the ACBGBI guidelines suggested that the radiotherapy, the morbidity from the radiotherapy is significant to the point that it negates the benefits of organ preservation, because these patients got lots of tenesmus and pain from the rectal radiotherapy. And currently, the Star Trek trial and the Click trial, what they're going to try to do, and in terms of organ preservation, they're trying to use a different approach. Instead of providing radiotherapy to the rectum, they're trying to provide to get a special. I think they what trying to do is, instead of giving radiotherapy to the rectum, just trying to give radiotherapy to the mesorectum to reduce the side effects from the radiotherapy.
Yep.
Okay.
Yep.
Fine. I think this is just go through that. Just make sure that we haven't missed anything. Okay. So this is part of the ACPGB guidelines. So what they say here is, best operative radiotherapy may be considered for high-risk patients who are unable or unwilling to undergo TME surgery. However, the benefit of adjuvant radiotherapy in reducing recurrence following local excision remains unproven. Okay, and this is a follow-up protocol they suggest for patients who undergo local excision. If you either going to survey the patient or just do local excision, this was suggested that you need to do. You need to do endoscopic assessment every 3 to 6 months, and MRI pelvis every 3 to 6 months, and CT scan every 12 months. And this should be continued till up to 3 to 5 years. So this is a recommendation from ACPGBI about if you are going to take the approach of organ preservation via local excision. Okay, and this is a bit of a complications of TME surgery. So you've got 30-day mortality is up to 6%. This is the American data. This is not the UK data. And don't forget, with low anterior section, you've got about 38% of bowel dysfunction. In terms of LARS, urinary incontinence up to 39%, and sexual dysfunction up to 45% in men and 29% in women. And as well, there is a percentage of patients they may need to undergo AB resection rather than just anterior resection with continuity of the bowel. Okay, so it's very important just to look at these guidelines from the Association of Coloproctology about rectal cancer.
Yep.
Okay, I think that okay, good. Yeah, I think you're done very well, Amy. I think it is very, very nice Viva, I would say. Okay, so shall we go to the next case?
Thank you.
I don't know what the next case is. Okay, fine. I think it's a case of Crohn's disease. Anyone willing to take this case? Just share it. I think that this case would be as well suitable for a colorectal examinee. So anyone from the colorectal guys wants to take this case? We'll just share it in a second.
I can go if you would like.
Yeah, it's fine. So yeah, I will share it in a minute. Just I'm trying to work out this thing. Okay. Okay. Can you see it now?
Yeah, I can see it.
Okay. Yeah, fine. We'll just have a sip of water and then we'll go through the case. So you got this 35-year-old male who's known to have Crohn's disease being referred to your clinic for consideration of surgery. So you are seeing the patient in the colorectal clinic. So how you are going to proceed with this patient?
First of all, I need to take detailed history from this patient, including his the duration of IBD, what sort of medication he had been taking, any sort of complication or previous surgery he had undergone, and how is he compliant with the medication, and what is the reason he was referred for surgery. Also, I need to consider any significant comorbidities, any associated malnutrition, which is very common with Crohn's disease, which might impact any intervention needed to be done. And also, I need to consider any reversible high-risk factors like smoking or other factors.
Okay, so fine. So the history saying you said duration of disease. So the patient been having treatment for Crohn's for about 3 years now. He tried multiple medications. He currently on infliximab. He is a very heavy smoker and is trying to cut his smoking down now to about 10 a day. He's not on any medications. He doesn't have any significant comorbidities. His main concern from the surgery is that he's very adamant not to have any stoma at all, and he hasn't had any previous operations. And over the last 3 months, he's been having increasing abdominal pain, which is spasmodic, worse after eating, with bouts of bloating and vomiting, but no diarrhea. So his gastroenterologist has a concern that his disease is progressing. And as I said, he doesn't want a stoma at any cost, and will die if he and not have a stoma. So how are you going to address his concerns?
For combination of assessment, I need to see the phenotype of this Crohn's disease. Either it is limited to the small bowel, or it is colonic, or combined small and large bowel. And if there is any complication, fistulization, because there is 3 presentations, and for the Crohn's disease, it could be either inflammatory or structuring or fistulating. My main concern from this presentation, he had some obstructive symptoms. I would be concerned about structuring Crohn's disease, but I will need to review up-to-date scans if he had MR enterography or any recent endoscopy had been done, and if there is any suspicion of any dysplasia or anything which might impact the intervention as well.
Okay, so the patient tells you that his gastroenterologist told him that he now his disease is causing narrowing of the bowel, and they think it's better for him to have an operation because medical treatment will not be effective with the structuring anymore. So on examination, he got some mild abdominal distension and mild tenderness in the iliac fossa with no other findings. And you look at these investigations. So his bloods, he's anemic with hemoglobin of 85 grams per liter, and all the other blood results are normal. You look at his CT scan, and CT scan telling you that he got terminal ileal Crohn's disease with some structuring. So this is the image of the CT.
Yeah,
yeah. Can you see the CT?
It is quite small, but I can see there is.
I'll try to make it a bit.
Yeah.
Sorry, just to try to get it a bit. No, it's even getting smaller.
I can see there is some narrowing at the terminal ileum with structuring and with upstream small bowel dilatation, which is consistent with the structuring ileal disease. And from this phenotype, this looks to be ileocecal Crohn's, which is the most common presentation for the Crohn's. But this patient probably wouldn't be fit for any structural plastic given the site of the structure, so he will benefit from ileocecal resection.
Okay, so this is MR enterogram, which is confirming your suspicion of a terminal ileal Crohn's disease with luminal narrowing. Okay, so would you do a colonoscopy for him or look at the colonoscopy?
Of course, yeah, I would consider colonoscopy to assess the extension of the disease because it might affect the extent of my resection. And I need to do assess for the colon. But there is few risk factors need to be addressed before any surgical intervention because he had to stop smoking.
So what criteria, what things on colonoscopy that you want to rule out?
I need to exclude first to know the extension of the disease in the colon, any evidence of dysplasia.
Okay, so the colonoscopy of the colon is normal, so there are no signs of colonic Crohn's disease, and the biopsies from the colon are normal. Biopsies from the terminal ileum showed inflammation with active Crohn's disease.
Yeah.
So the patient was discussed in the IBD MDT, and the decision was to refer for surgery. So now the patient is in front of you, and you are going to discuss with the patient the options for surgery.
Okay.
So first of all, with all this information, are you convinced that this patient needs surgery, or you are going to refute the decision of the IBD guys?
So I just need to confirm if there is any evidence of stricture. I need to confirm with the radiologist that stricture or just inflammation, which is caused narrowing of the lumen. Because if it's just inflammation, it can be reversed with medical treatment. But if stricture, it will not be reversed with medical treatment. So this one need to be considered MDT.
Okay. Yeah, so the radiologist say it looks like a fibrotic stricture. It doesn't look like to be inflammatory stricture.
Still, because there is active inflammation, I wouldn't consider stricturoplasty in this case because there is high risk of fistulization. So this patient...
But would you consider surgery?
Yeah, I would consider surgery,
Okay.
but I would be concerned about any anastomosis in the presence of active inflammation.
Okay, so you consider surgery. You are going to discuss the surgical options with the patient. And remember, the patient told you previously that the patient doesn't want to have a stoma at any cost.
Yeah, I didn't try to discuss this with the patient before full assessment to see what my options are. First of all, we need to correct any reversible causes like the anemia, which need to be corrected. And of course, we need to stop smoking, which increase the risk of complication.
Okay, so can I just ask you, when during the exam, it's very important when you say, I want to correct a reversible cause. You say, for example, I'm going to correct anemia. You say what you're going to do for it. Okay, don't wait until I ask you. So you say, okay, it's fine. He's got low hemoglobin, he's anemic. I want to do this to correct the anemia. So, for example, giving them iron infusion, okay, and so on.
Yeah, of course, because this patient is symptomatic and obstruction, so I need rapid correction of anemia as I can. So I would consider infusion rather than oral iron. And probably because he had active Crohn's, so the absorption wouldn't be efficient anyway. So I would go for parenteral iron infusion. And also I need to check for albumin if any signs of malnutrition. Elemental diet might correct his malnutrition, and he need to stop smoking. But I would discuss with this patient that possibility, given the intraoperative finding, I might need to consider stoma, because it might not be safe for him to have anastomosis if there is active Crohn's in the small bowel, and I don't need to excise much of the small bowel because it might complicate with small bowel intestinal failure if I have to excise much. So I need to excise the stricture segment, which is not reversible by medical treatment, and then we need to consider medical treatment after surgery for the inflammation of the small bowel.
Okay, fine. So the patient now is asking you, what operations are you going to do for me?
So operation, I will do limited resection, ileocecal resection, but I would be very reluctant to do any anastomosis for him if there is active disease. So I would consider temporary ileostomy until the active disease had been controlled with medication, and after that we can consider reversal of the ileostomy.
Okay, so the patient is asking you why you're not able to join my bowel again. What's the problem? You just stitch them together and it will be okay.
It isn't. I would explain to the patient that we are not doing things because we can do, but we have to consider risk and benefit from it. Because technically we can do it, but the risk will be high, and there is high risk of fistulization, and he might become very unwell and might end with intracutaneous fistula, and he might end in intra-abdominal catastrophe, which is not recommended for him. So we are trying to take him out of troubles, take him out, correct his obstruction at the moment, try with medical treatment to relieve the inflammation, then we'll consider rejoining his bowel.
Okay, fine. So the patient is coming around a little bit after you explained about the risk of anastomotic leak and sepsis, and this may be life-threatening, and eventually, if he got leak, you're going to give him a stoma anyway to save his life and so on. So he starts to come around a little bit and says, okay, but how am I going to manage this bags that you're going to give me?
So before with surgery, you have to, we'll discuss this with the stoma nurse. She will take you through all the process and preoperative preparation for that, and how are you going to manage the stoma. And early in the postoperative period, you will see the stoma nurse, which will start training you how to manage the bag. And of course, we will keep an eye on you after the surgery, and we'll repeat the investigation at appropriate time and discuss again in the MDT when you are fit enough to go for surgery to resume the bowel continuity.
Okay, so the patient is asking you, would you promise me that this will be a temporary stoma, not a permanent one?
I cannot, but most probably it will be temporary, but I cannot give you a definite decision because we don't know the extent of the disease or how your bowel is going to behave after surgery, because it is quite unexpected, the course of the disease. So my consideration at the moment, we are planning to do reversal at some point. But if you start to have complication and the small bowel is still inflamed, not responding to medical treatment, or there is high risk of joining you back, so I might not be able to join you.
Okay, so fine. So the patient has come around a little bit, started to be convinced about the stoma and surgery, and tells you, fine, I will take a bit of time, think about it, and come back to you with a decision. So you put the patient on the waiting list in preparation for surgery. So what are the other preoperative preparations that you would consider? You said we're going to give this patient IV iron to correct his anemia. Okay, maybe consider addressing his nutrition a little bit. Make sure that the patient is not malnourished. Okay, the patient is currently on infliximab, with he's still taking. So are you concerned about the fact that this patient is still on infliximab? Is it going to affect, or may you change your decision about surgery?
It's quite a tricky situation because there's risk with biologic. It is not as much as the risk of corticosteroid, which have to be tapered before the surgery.
What do you mean there is a risk with biologics? What risk you mean?
The risk is the wound healing, and if there is any plan for anastomosis, it might be affected by risk of biologic. But in the other hand, the biologic help to control the disease and improve the postoperative outcome. So this is something we cannot we need to consider, but we cannot in the presence of active Crohn's, we cannot stop. Otherwise, will be flare of the disease, which might be catastrophic.
So why are you worried about the biologics? Because why the biologics will impair your wound healing or affect your outcome after surgery?
Infliximab is the anti-tumor necrosis factor, and this inflammatory process is the active phase of wound healing. So it affects the inflammation, it will affect the wound healing, and if there's anastomosis, it will affect the healing of anastomosis.
Okay, so you mean inflammation is important for wound healing? Fine.
Yeah.
So inflammation is the second stage of wound healing. It's very important here as well to know what are the stage of wound healing, because you may be asked about them.
Yeah.
Okay, so you got mainly 3 stages of wound healing. I think we're not going to spend much time about this, but you need to all of you need to be aware of the stages of wound healing, because it's a common question in this exam.
Yeah.
Okay, so patient is on biologic treatment. So is there any time frame from the last dose of biologic before you do your surgery?
I'm not entirely sure, to be honest, but I think it shouldn't be affecting my surgical decision, but I'm not sure about the exact time.
Okay, so normally infliximab or most of the biologics would have about 8 to 12 weeks half-life, and this why the patients are. If you look at most of patients who are having biologic treatment, they have biologic treatment every 8 weeks. And the reason for that is the half-life of the drug. So the infliximab and most biologics will be effective for 8 weeks, as they continue to be circulating in the blood for 8 weeks. So most studies have suggested that if you're going to do surgery for patients who are on biologic treatment, it should be after 8 weeks from the last dose of the biologic treatment. And then for post-operative biologic treatment, you should wait for 4 weeks after the surgery before you start your biologic treatment again. But the duration is variable between studies. It is 8 to 12 weeks. Okay, and as we said, tumor necrosis factors 1 is a very important factor in the immune system. It has a very important role in angiogenesis and collagen synthesis, and this is why it may have a role in reduced wound healing. Okay, other factors that can affect the surgical outcomes. These are the based on evidence. So either anastomotic leak or surgical site infection. These are the important factors. The nutrition, as you mentioned, albumin and hemoglobin. These are the surrogates of nutrition. Also, albumin is considered as one of the inflammatory signs of inflammation. Sorry, not signs of inflammation, signs of sepsis. So patients on chronic sepsis, they would have low albumin. Okay, in this context as well, it's very important to know how to assess nutritional status. Okay, because you can get a question about this. Okay, if you say, I'm going to assess the patient nutritional status, make sure the patient is not malnourished, how you are going to assess that, what tools you are going to use to assess the nutritional status, and there is MUST tool that you can use. Also, smoking is very important. Smoking is one of the independent risk factors for surgical site infections and complications after surgery. Also, the Crohn's disease activity index. It is not, I would say, not very well mentioned, but if you know, just read about it, just know what it is. Okay, it's not completely important to know. Diabetes and the previous bowel resections. So these are the main 5 risk factors that have shown to have impact on the outcome after surgery for inflammatory bowel disease: nutrition, smoking, Crohn's disease activity index, diabetes, and the previous bowel resection. Okay, fine. So you discuss the surgical options of the patient. You use a big observation for limited right hemicolectomy. So on the day of surgery, you see the patient in the morning, and the patient tells you that 3 weeks ago, he had severe abdominal pain with increasing diarrhea and vomiting, and he was admitted to the hospital, and I had a CT scan at the time, and they told him he had a flare-up of Crohn's disease. He was given some treatment, and he was sent home. He tells you that he's taking these tablets every day, every morning, every day since, and is asking you, do you want me to take these tablets today, this morning?
So I need to review the history for this admission, and if there is any available data about this, what is the cause of the admission. I need to review the scan, and I need to review his medications. I'm assuming with the active flare of Crohn's, he might be on steroids, which is increasing the risk of surgical complications like wound healing, burst abdomen, and as I mentioned, I'm not planning to give him anastomosis, so it wouldn't be my main concern now, but my concern now would be in high dose steroids.
Okay. So the patient shows you the tablets, and it seems that he's taking about 6 tablets of prednisolone a day. It's about 30 milligrams. What you're going to do?
I will assess the patient's symptoms now. I wouldn't proceed for this elective surgery, given that the fact that he had on high dose steroids, and there is possible complication from this high dose steroid, and it is elective surgery, not emergency. So I need to.
So what do you mean by high dose steroids?
It is more than 25 milligrams per day is considered high dose steroids.
Okay, so why this would have an impact on the surgery?
There is risk of, from anesthetic, he might go in adrenal crisis after surgery if he's not properly replaced. If this steroids hadn't been replaced appropriately, and there is risk of wound complication, burst abdomen, wound dehiscence, and there is a risk
So
of
will,
infective
will your decision be different if he was only taking 5 milligrams of prednisolone?
Yeah, of course, it is low dose, so it wouldn't have significant effect on the surgical outcome.
Okay, so high dose steroid would have significant impact on the outcome from the surgery, increasing the risk of wound complications, risk of anastomotic leak, and risk of wound dehiscence, and so on. All the complications that you all you know. So do you know how much risk, if the patient is steroid, how much risk of anastomotic leak he may have?
I'm not sure about the number, but it might be around 20%.
Yeah, I think it's about 20%. Okay, fine. So you identified the medications. I think in this context as well, that you may get asked about the mechanism of action of steroids and how steroids impact the immune system. And as we discussed, there is significant effect from steroids on the surgical outcome. And highly likely, if you're going to operate in this patient, you would have to give them a stoma. But it's better not to proceed with elective surgery if patient is on high dose steroid. Ideally, you need to bring them to less than 20 or less than 15 milligrams of prednisolone. Okay, so do you know the mechanism of action of steroids?
It is one of the anti-inflammatory disease, anti-inflammatory medications, but I think it is inhibitory for. I cannot remember it now, but I think they are inhibit the chemotaxis and inflammatory migration of the white cell to the site of the inflammation.
Okay, yeah, it's the same principle. So it's anti-inflammatory, it reduces the inflammatory phase of wound healing, and eventually it affects wound healing. Okay, so you postpone the patient surgery and ask the patient to wean the steroids, and now you are on call, and this patient is presenting as an emergency with acute small bowel obstruction. So what are you going to do for the patient?
So it is a different situation now. I need to assess the patient according to CRISP protocol, make sure that he had been resuscitated, EBC had been done already, assess any signs of sepsis, any signs of dehydration, any electrolyte imbalance which you need to be corrected. I would consider drip and suck in this situation, put NG to decompress the small bowel, give him fluids, observe for urine output, and check the basic bloods including lactate and CRP and white cell count for other marker of inflammation. And then I will consider getting CT scan first for assessment of the degree of obstruction or any associated complications.
Okay, so the CT scan shows that the patient got mechanical small bowel obstruction, likely from a stricture in Crohn's disease. The patient is still taking 10 milligrams of prednisolone a day, okay, and he's not resolving with conservative management.
In this case, the patient needs to be considered for emergency surgery, so I would calculate the NELA score for him, which is for assessment of the associated mortality with the emergency laparotomy. And if there's more than 5%, this means that he might need to be admitted to ITU, and the anesthetic consultant colleague should be at the theater at the same time. And I would speak to the patient with the options, given that he has not fully assessed and we don't know the activity of Crohn's in the small bowel. So my main consideration at this point, I would be just to take him out of trouble, limited resection, and depends on the intraoperative finding, I might be able to join him or give him temporal stoma. And I need to speak to the family as well.
Okay, so do you want to involve the gastroenterologist?
Yeah, I will involve gastroenterology, IBD nurse, and the stoma nurse as well to be involved in the decision and for stoma marking in case I need to give him a stoma. And because the patient still is on steroids and had been for a long time, so probably he will need to continue this after surgery, and he need to stay on his medical treatment for any remnant Crohn's disease in the small bowel.
Okay, so fine. So you operated on the patient. The bowel proximal to the segment of Crohn's looked healthy, was not very distended. You took a decision to join the patient up. So you joined the patient up. Patient did well. Patient on day 5 now, ready to be discharged. Are there any instructions or any advice you're going to give to the patient? So, and I'll be specific here, just anything that you want to tell the patient to help reduce the recurrence of Crohn's disease.
Yeah, there's some studies suggest that metronidazole for 12 weeks after surgery might reduce the chance of recurrence. For 100 milligram 3 times daily for 12 weeks can reduce the chance of recurrence, but there is no strong recommendation for it. It depends on the practice. In my practice, I would consider giving him.
Okay. Anything else?
This patient is high risk for VTE, so I would just encourage him to be quite mobile after surgery and drink plenty of fluids, and to just need to monitor his progression after surgery and adequate nutrition, and to avoid smoking.
Yeah, okay, it's very good. So it's very important. This to avoid smoking. This point is very important, and it will be helpful if you say you are going to refer the patient to in the community, ask the GP to refer the patient to smoking cessation advice, so someone would help him stop smoking. Okay, so anything else that you want to consider in the follow-up of this patient?
I would just get advice from the gastroenterologist if they need to see him in the clinic, and I think they can use fecal calprotectin just as a marker of activity of the Crohn's, and he need to get repeat bloods to assess for the anemia which had been there before surgery, and for albumin, and check his nutritional status.
Okay, so would you consider doing a routine colonoscopy after a year to check for recurrence?
Because the disease was limited to the small bowel, there wasn't any active in the Crohn's, and it depends on the specimen. If the specimen shows there is Crohn's in the colon, then we can consider colonoscopy, but there is no guidelines to say that he needs colonoscopy.
Okay, so the post-operative histology tells you, okay, it's fine, it's all confined to the small bowel. There is the active Crohn's disease in the small bowel with the strictures. The colon is clear, okay, and then 1 year later, the patient is coming back with pain in the right iliac fossa, and you think the patient may have recurrence. So where do you think the first site of recurrence would be?
The most common site of recurrence will be the site of anastomosis, the anastomotic stricture.
Yes, yeah, exactly. So that's why there are some studies now suggesting that these patients may benefit from a routine follow-up colonoscopy after a year to have a look at the anastomosis and see if they got any recurrence for the anastomosis. Okay, so one other point of discussion that may be discussed in this context as well may be the type of anastomosis that you're going to do for these patients. So what type of anastomosis that you routinely use?
So the guidelines or the recent data suggests that for small bowel colonic anastomosis, stapled anastomosis is quite safer than hand-sewn anastomosis. So I will do stapled iliocolonic anastomosis for this patient.
Stapled side-to-side anastomosis.
Side-to-side, yeah, side-to-side.
Okay, and what is the evidence? Any particular evidence?
I cannot recall it now, but I think it was the European guidelines suggest that there is.
Yes, so the European Society of Coloproctology guidelines recommend side-to-side stapled anastomosis, but the ACRS guidelines are a little bit different. So they say there is no difference between hand-sewn anastomosis or stapled anastomosis for ileocolic resection for Crohn's disease. On the other hand, the Association of Coloproctology, the European Society of Coloproctology, they recommend side-to-side stapled anastomosis. Okay. The other questions that you may get asked as well in this case is, what do you think about cone OS anastomosis? Would you consider doing a cone OS anastomosis?
There is emerging evidence about it, but in my practice, I haven't been trained to do it, so I'm not quite confident about doing it. I know that it's a role just to give wide anastomosis, which decreases the chance of recurrence or anastomotic stricture later on, but I haven't done it in my practice.
Okay, so I think it's knowing the principle of the anastomosis in terms why Kuno has suggested this type of anastomosis is basically it's the side-to-side wide hands-on anastomosis, and the theory was anastomotic stricture happens because of narrowing of the anastomosis and with some element of obstruction, and this would lead to development of recurrence. And the whole idea is just to create a very wide anastomosis. And also one of the principles is when you look at the side-to-side anastomosis, there is an area where the flow of bowel content will be interrupted, and this will create an area where some of the bowel content just accumulate in the end on the end of the anastomosis. When you look at the anastomosis, you would have a part of the anastomosis that is not dynamic, and they say possibly some of the bowel content will accumulate in this area and cause some sort of obstruction and dilation with time, and this increase the risk of recurrence. Okay, so in this context as well, you may get asked about something called the MERCAT trial. Do you know what is the MERCAT trial?
No, I'm not aware.
Okay, so it's a trial that is currently being run in the UK by Professor Steve Brown in Sheffield, and he's doing this trial to look at the cone OS anastomosis. Okay, fine. I think if this is the ACRS guidelines about the effect of steroids and tumor necrosis factor alpha, anti-tumor necrosis factor alpha on the outcome of surgery. It's very important as well in inflammatory bowel disease to look at the gastroenterology, British Gastroenterology Society guidelines for management of IBD. They are very thorough and they are very detailed as well. Okay. Worth mentioning as well the Buschini trial. Has anyone heard of the Buschini trial? Fine. So it's an American trial that has been published in 2022, and so basically this is the most recent evidence now about surgery for IBD and the effect of tumor necrosis factor alpha inhibitors. And what they looked at is if there is any effect of biologic treatment on the outcome after surgery, and the conclusion from that study was that there is no association between surgical site infection and the administration of tumor necrosis factor alpha inhibitors before surgery. So the independent risk factors that they found in this study that are related to infection, surgical site infection, are mostly the preoperative corticosteroid use and the active current smoking. Okay, it's worth knowing as well. This trial. Okay, I think this is the end of this scenario. Thank you very much, Mohammed. Thank you. Well done. Okay, fine. I'll just stop sharing this scenario, and then we can go for another scenario. I think we'll go for a generic general surgery scenario. So anyone welcome to take this coming scenario. Okay, let's close this one now. Okay, we'll share this one. Okay, can you see this, guys? Hello?
Yes, we see this.
Oh, it's fine. So it's a, I would say it's maybe a straightforward appendicitis case. Anyone willing to take it?
Happy to take it.
Ahmed?
Yeah.
Hi, Ahmed. So what is your specialty?
Apogee.
Apogee. Okay, fine. It's a basically a generic general surgery case. So you got this 70-year-old gentleman who's been admitted under your care with right lower quadrant pain for 3 days, nausea and vomiting, classical history of appendicitis. And so how you are going to approach the patient first?
First of all, usually the patients came through A&E, so I would review the patient as a case of critical care illness, the CRISP protocol, making sure the patient airway breathing, he's not shocked circulation-wise, and then considering these numbers, so most probably he's in sepsis, white cell count 20, CRP 200. So advice started IVI, see the EWS, the observation. If he's having high spiking temperature or scoring more than 3, I would advise start antibiotics even before the CT scan. And then, first of all, history and examination wise. And history, considering he's 70, although this is an acute emergency, will ask for classical pain symptoms associated with appendicitis, but I would also ask for briefly regarding a history of bowel cancer, regarding weight loss, anemia, bleeding rectum, family history of bowel cancer, the last colonoscopy since he's 70, whether he joined the bowel cancer screening program or not. And the examination wise, I would also examine his abdomen, looking for tenderness, of fullness in this area, and maybe even BR is required, and sometimes some even if there is any signs of hepatomegaly. Then we'll start the management, including, as I said, antibiotics, fluids, arranging a CT scan. He's 70, so I would look for appendicitis. Any white cell count in adult age group above 17 or 18, I would advise CT scan to exclude the perforated viscous.
Okay, fair enough. So as you mentioned, this is a blood test, white cell count 20, CRP 200. He got an HV of 95, which previously was 140. Heart rate 110, blood pressure is 110/70, and he got normal deformity status 0 to 1. So CT scan show this picture. Can you see the CT scan image?
Yeah, I can see there is a free fluid in especially around the right iliac fossa. I can see a thickened cecum. I think thickened cecum. I'm not sure, but definitely there is signs of perforated appendix.
Okay, so you can see some fluid collection is right iliac fossa with fat stranding. Looks like some kind of inflammation there. Okay, and there's a CT report says perforated appendicitis with moderate amount of free fluid in the abdomen. This is what they say.
Yeah.
So it's a like there is kind of, so if you learn some of what we call them is some words that you can say for any CT image. For example, if you say the single slice of CT abdomen pelvis showing so and so, and then after you finish, you say, I want to look at the CT report, have a look at the rest of the images, and discuss the images with the radiologist, and just like keep saying this for every case of CT or every radiological image that you say, and this way that you wouldn't miss anything.
Yeah, I keep forgetting this, but I hope.
Yeah, it's very important. It's like, okay, just a sentence, just learn it, say, and learn to say it in every image that you see. So there's a single slice of CT or maybe 2 slices of CT scan of abdomen pelvis with contrast, showing so and so. And after we finish, say, I want to have a look at the rest of the images, have a look at the report and discuss the images with the radiologist. And this way you wouldn't miss anything.
Yeah, agree.
Okay, so this is one of the CT images, the slices, and this is another slice. Okay, what can you see on this slice?
So that's tell you how bad it is. This again, it's just an axial thin slice of CT with IV contrast. I think with oral and IV contrast. The stomach is full of contrast material, and there is a free fluid in the prehepatic perisplenic area also. And yeah, yes, yeah. That's
Okay,
right.
so you think this patient got peritonitis maybe from the perforated appendix?
I can't hear. I can't get it. What you said?
Sorry, what I mean is, so you can see there is free fluid around the liver and around the spleen, and you think this is likely peritonitis from perforated appendix.
It's hardly to have perforated appendix causing perisplenic collection. I would start to think about more differential diagnosis. Likely, rarely I'd see perisplenic collection from perforated appendix. I've seen it once in my life.
Okay, so because you mentioned earlier in your assessment that this patient is anemic, and you asked, as his age is 70, you asked about symptoms suggestive of bowel cancer.
Yeah.
So would it be a perforated cecal cancer?
Yes, one of the possibilities, especially if he's anemic, and cecum is more. Yeah, I think especially the area with fat stranding was around the cecum, so either perforated appendix or perforated cecal tumor. Especially, I was seeing some thickening in the cecal wall.
Okay, so yeah, so you may think that maybe something else going on. So you be a little bit cautious when you approach the patient and assess the patient. Okay, fine, fair enough. Okay, so what you're going to do with this for this patient now?
Whether it's appendix or tumor, patient's a bit septic, free fluid, peritonitis. So definitely he deserves some sort of diagnostic laparoscopy.
Okay, so you are planning to do diagnostic laparoscopy. How are you going to consent the patient?
So I would consider speaking to the patient about his CT finding, about our provisional differential diagnosis, and based on that, would consent him about diagnostic laparoscopy plus minus appendectomy plus minus bowel resection, including right hemicolectomy plus minus stoma, and will inform the patient. Maybe just going to be just diagnostic laparoscopy with washout and put a drain, and then he might need an MDT and colonoscopy later. So all of definitely plus minus laparotomy. So I would give the patient whole possibility during the surgery, starting from simple appendectomy to the laparotomy with right hemicolectomy and stoma. Okay,
so the patient asks you why stoma? Why do you think you may need to give me a stoma?
So he will be really septic. So I wouldn't advise. I know ileocolic anastomosis is one of preferable anastomosis, but not in this situation. He's septic. He's having peritonitis. So definitely stoma will be my choice rather than putting him in a risk of leak or risk of anterior cutaneous fistula.
Okay. Yeah, fair enough. Okay, fine. So you book the patient for diagnostic laparoscopy. You took the patient to theater, and then you put the camera. Once you put the camera in, this is what you can see in the pelvis. This is what you see around the liver, and this is what you see around the spleen. What are your thoughts?
Well, it's a free fluid deemed to be blood, so hemoperitoneuum, but from where? This is not pus, so.
Yes, fine. You are asking yourself.
Yeah. And he's a male. I'm trying to see what's going on, but I mean, these are the area of collection, so we have to investigate thoroughly from the stomach to the last part of the bowel. What is causing this? Is mesenteric bleeding or a perforated appendix with bleeding around it? But definitely it's a miss there. So I have to do thorough small bowel examination, small and large bowel examination to investigate which part of the bowel or mesenteric caused such a bleeding.
Yeah, right. So it's good thinking, but when you are faced with this finding on a laparoscopy, so the first thing that you need to ask the anesthetist is what?
First thing to ask?
To ask the anesthetist. So the anesthetic
yeah,
team,
I will ask definitely about whether there was a drop in hypo blood pressure, because I might injure something during the introduction of my pneumocranium.
yeah, because remember that the anesthetic team, they just take it simply as an appendix operation. Okay, they are not aware that you have found this blood. So
well, yeah, but before that, in the in the huddle, I will mention to the team that I'm expecting like 30 or 50% possibility of a tumor that I will convert to.
Okay, yeah, but what I mean is, so the anesthetic team, they don't know that the patient is bleeding. So with such amount of bleeding, you need to make sure the patient is hemodynamically stable.
Yeah.
And then you need to think about, okay, so what is the source of this bleeding? Because as you mentioned, would it possible to be from an injury that you done during your laparoscopic access?
Yeah, I'm suspecting that, or this is my top worries during this. Yeah.
Yeah, it's a possibility, but it's still unlikely, because when you cause bleeding from laparoscopic access, you
It
may
will not cause for quadrant quickly. Yeah, I agree.
Yeah, so or everything is still possible, because you are still at the stage of assessment. Okay, so you need to consider all the possibilities, and now you're doing a diagnostic laparoscopy. So as you said, you need to assess all the 4 quadrants of the abdomen and pelvis. Okay, see if you are able to find a source of bleeding. Okay, and make sure throughout all of that the patient is hemodynamically stable, and alert the anesthetic team that they may need to get some blood and start giving the patient blood transfusion. Keep eye on the patient coagulation profile, and make sure as well that the patient does not have coagulopathy, and all of that. Okay, and then you start your assessment. So, you will start examining the 4 quadrants of the abdomen. Okay, if you are comfortable doing this laparoscopically, go ahead and do it. But you are not comfortable doing it laparoscopically, it's very fair to say I'm going to convert it to a laparotomy.
Yeah.
Fine. So you continue your laparoscopic assessment. You wash out the pelvis. Okay, you take all the blood away. No active bleeding there. You wash out the right upper quadrant. No active bleeding there. Still, you look at the right iliac fossa. Indeed you find there is an inflamed perforated appendix. Okay, and when you look at the left upper quadrant, you see this active bleeding from the spleen. So this is your assessment. So you got an inflamed perforated appendix with a collection of the right iliac fossa, and you got actively bleeding spleen. What you're thinking now? What's the priority?
The priority now, most likely, will take the appendix out, whether during laparoscopy or during through laparotomy. But the priority for the first is to control the bleeding.
Okay, and how are you going to do that? So you think it may be bleeding from the spleen.
Yeah.
So how you are going to approach that?
Yeah, after sectioning the left upper quadrant area, I would advise for compression through laparoscopy, and then reassess if this is still actively bleeding, and if I'm not capable doing laparoscopic splenectomy.
So can I ask you? You said compression via laparoscopy. What do you mean? What you are going to do exactly?
So I will insert gauze 3x4 gauze, like 2 or 3, and then compress at the area of bleeding using my instruments, and see how it goes. after like a couple of minutes, then reverse these swabs and see if it's manageable or most of the bleeding gone and just still bleeding from the raw surface. At that point, I might advise putting some surgicine and then reassess. But if still actively bleeding with copious amount of bleeding, I might need to convert to laparotomy for splenectomy and appendicectomy at the same time.
Okay, so you've done that. You've taken the swabs out. The patient still bleeding, and you think the bleeding is significant. It doesn't seem that it's going to stop with simply with Surgicel or Flucid. And you convert, as you said, you convert it to a laparotomy. So what you are going to do after you convert to a laparotomy?
I will start with splenectomy first because the appendix will not go anywhere, but the spleen is still actively bleeding. So I will start with the spleen. First of all, I'll ask the team at the time of conversion that to prep a large swab from me to do backing at the time of conversion to laparotomy.
Okay.
And then try to bring the spleen, like any emergency splenectomy trauma, bring the spleen up and start ligating the vessel, taking the spleen out and start doing some transfixation and proper tie, making sure there's no bleeding anymore in the area.
Okay, so you mobilize the spleen, you detach the spleen from all the attachments.
Yeah.
Okay, bring it towards the midline as much as possible, and then you take the pedicle.
Yeah.
Either you stable it or transfix it. Okay, it's fine. And you've done the splenectomy, you've done the washing out, and you've taken the appendix out.
Yeah.
Okay, so so what do you think? What's the cause of the splenic rupture or the bleeding from the spleen?
Well, it depends, because if it's varus needle, the methods of creating pneumoperitoneum, it might cause bleeding to left upper quadrant organs, including spleen. I'm doubting that my pneumoperitoneum, if it's open cut technique, to do such bleeding from spleen, but all of these.
Remember as well, the patient came anemic, so the patient came with an HB of 95, which has dropped from 140. So
still, there is a possibility of a traumatic rupture spleen, but I can't tell or relate this to perforated appendix. I'm not quite sure to answer this.
Yeah, exactly. So there are lots of causes of traumatic spontaneous splenic rupture, and the most common cause of these are infection. And there are some reports saying that patients with sepsis, severe sepsis, that sometimes they can have a spontaneous splenic rupture. But there are lots of other causes of spontaneous splenic rupture. So you've got infection, hematological diseases, amyloidosis. So there is a list of these causes. I think it's worth knowing as well. Although it's uncommon, it's not very highly used for the exam, but just worth knowing, especially for the hematological diseases and patients with enlarged spleen. Because these are the kind of patients who can present with a splenic rupture after minor trauma, and it may come in the exam as a scenario of, okay, someone with a hematological disease after a minor road traffic accident, not significant external signs of injury, but they got a splenic rupture.
Yes, sir.
Okay, fine. In the context as well of splenectomy, definitely you will get asked about both the splenectomy vaccination and what are kind of the vaccines that you're going to give this patient after splenectomy. Okay, yes, fine. So I think all of you would be able to know that and read it. Also, both splenectomy, overwhelming sepsis. This is very common for the exam. It's some things that you need. It's some musts for the exams. You need to know that. Okay, so fine. So you did the splenectomy. We're taking the appendix out. Are you going to leave drains?
Yes, sure.
So where are you going to leave your drains?
Definitely one in the pelvis, but I might also put another one in the left upper quadrant area.
Okay, so fine. So you want to leave a drain in the splenic bed in the left upper quadrant and another drain in the pelvis.
Yeah.
Is there any evidence about leaving drains?
I'm not quite sure, but this is my practice. Especially during splenectomy, raw surface will bleed like more, not most of the time, but in a quite percentage that you would leave a drain to avoid.
Okay.
Yeah.
Yeah, fair enough if this is your practice, but it's the evidence is there is no rule for the drains in most surgical procedures now, because even they will tell you if the patient is bleeding, of course, but they if the patient develop a collection, they would have no role in draining the collection because some of these drains get blocked. But it's fine. It's not something that you can anyone say it's wrong. It's just your practice.
Yeah.
Fine. So you leave the drains in, and then you see the patient on day 4 post-operative. You can see the patient having increasing abdominal pain and tenderness, and he got persistent output from the drain in the left upper quadrant, about 500 a day, which is a mix between serous, serous and sometimes maybe like a turbid fluid.
Mm-hmm.
So what are your thoughts?
My main concern here will be a pancreatic fistula due to the splenectomy. So the distal part of the pancreas may fistulate into this surface and cause a fistula. I would investigate by taking analysis from the drain fluid if it's high in amylase or lipase. So definitely this is a pancreatic fistula.
Okay, so what do you mean high? How much high?
I think three times since it's taster, so I wouldn't be pretty sure. I think it's 3 times higher than the normal level in the bloods.
Okay,
yeah,
fair enough. Okay, so any investigations?
Maybe MRCP with pancreatogram might give us a picture, but I'm not quite sure, to be honest.
Fine. So where do you expect the leak is coming from? You said from the tail of the pancreas, isn't it?
Yeah.
So do you think it is from a ductal injury or from just injury to the tissue of the pancreas?
How high is the output will consider us either giving us a picture whether it's ductal injury or it's just the surface of the pancreas.
Yeah, so it's a mix. So you say, you know, it's 500 ml, and the most of it like mix between serous fluid and the serous fluid. So not all of it is pancreatic fluid. So it's difficult to say how much exactly is pancreatic.
I wouldn't consider this is from ductal injury. Ductal injury will give us higher amount of fluid.
So because mostly it's just injury to the tail of the pancreas, and it's very unlikely to be a ductal injury.
Yeah,
so
that's my expectation. Yeah.
So I don't think MRCP will be able to tell you if there is any ductal, because MRCP it's pancreatography. So you're looking at the pancreatic ducts, isn't it?
Yes, I don't think I need some MRCP.
But again, it's fair enough because they do MRI anyway. So when you do MRCP, you do MRI of the pancreas, and if you do MRI of the pancreas, it will tell you if there is any collection. Fine. So it's basically like any routine post-operative case. So you do routine bloods, white cell count, CRP, maybe amylase. You do, as you said, you do amylase level from the drains, and you go to CT, and this is what you see in the CT scan.
So it's really quite sizable collection in the posterior surface and lesser curvature. I think it's advisable. It's not. I couldn't say it's a pseudocyst because it's not pancreatitis. I would say it's about a well-formed wall, enhanced wall, not enhanced wall, but there is a collection, and I think IR will get best benefits such a big collection.
Okay, yeah, fine. So it looks like a post-operative collection. You ask IR guys to drain it. They drain it for you, and then you got this persistent drainage. After 1 month, you still have drainage from the IR drain. It's about 50 to 100 ml a day. Okay, so and you think this is a pancreatic post-operative pancreatic leak and fistula?
Yeah.
So the incidence of that is about 5% after splenectomy. It's more common after traumatic splenectomy. And this is a very important thing to know is what is the definition of pancreatic fistula, and what are the grades? And you'll find this in the 2016 update of the International Study Group on pancreatic fistula. So definition and the grading of post-operative pancreatic fistula. And this is, I think if you do a Google search, you'll find it.
Yeah.
And as you said, the definition, the new definition is measurable volume of fluid with an amylase level more than 3 times the upper limit of normal in urine institution. And they grade pancreatic fistula into 3 types: A, B, C, A, B, and C. A is non-clinical, has no clinical impact, which is basically just biochemical fistula, where you find high amylase in the output from the brain, but it's not causing any significant clinical impact on the patient. And type B and C are B, where you'd need to do some kind of intervention for it, and C, where you may need to do surgery, intervene surgically, either by doing distal pancreatectomy or causing significant morbidity or mortality to the patient.
Yeah, reoperation and risk of death. Yeah, I've seen it now.
Okay. So yeah, so great. So that's fine. That's excellent. That's very, very good scenario. Yeah, thank you very much. You've done very well for that.
Yeah.
Okay. So fine. I think shall we do another scenario, another general scenario? So Muhammad Suleiman, sorry, you got your hand raised. Is it alt? Okay, thank you. Wael, do you want
I'm
to
taking it out, but I just...
Okay, no problem. Thanks, Mohammed. Wael Ramadan, do you
Yes.
You want to go for the next one?
Yes, please.
Okay, yeah, of course. Yeah. Give me a second. I'll just end this presentation and start the new one. Let's see this one.
Muhammad, just a quick question about the first scenario that done with about Crohn's disease patient. Is
Yes.
it colorectal or general? Because I'm more toward our GI. So am I expecting such a scenario, such a specific details in the Crohn's disease management in general?
I know not the full details as we discussed, because this is for, I would say, colorectal specialty. But now with the exam, there is a trend towards asking more detailed question for non-specialists. So you may get asked some more detailed questions about IBD, especially on emergency presentation.
Okay. Yeah.
And what we noticed over the last 2 years of the exam is people from other specialties have been asked more detailed questions on the the other specialties, which I mean is, if you are colorectal, you may get asked more detailed questions on the upper GI. I know some people from transplant being asked about how to do esophagectomy, and breast examinees have been asked about how to do a cystogastrostomy.
Yeah.
So it seems now they are tendency to ask more detailed questions. So I think it may be worth just trying to have a bit more depth of knowledge of the other specialties, not to the depth of being ST8 level, but maybe ST6, ST7 level, ST7 level.
Okay.
Because I think this is what we have noticed on in the last 2 exams.
Okay.
Okay, sorry, I'm just trying to find another general scenario. Should give me a second. Yeah, fine. I think we'll go for the penetrating chest trauma. Okay, I'll share that one. Okay. 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 Well, can you see the screen?
Yeah. Yes, I can. Yeah.
Okay. Fine. So you are the surgical consultant on call for the weekend at DGH. You just finished a laboratory on Friday night and ready to go home. Your ST3 calls you to come to help an ED with the resuscitation of a trauma patient who is 25-year-old, involved in a fight in a local pub and has multiple stab wounds in his torso. So he was brought to your DGH because it was the nearest hospital and the patient was unstable. The nearest trauma center is about 30 miles away. You are the most senior person in the hospital at that time, and you are asked to lead the trauma team. So who are the trauma team members that you want to call?
So in this situation, I would be keen to have the anesthetist and the ITU team and the A&E consultant with me. And if we do have the ENT consultant too on board with us. So mainly the ENT and ITU and the anesthetist for me. And yeah.
Okay. Yes, it's important as well to be familiar with the trauma team members, because if you look at the trauma team members in your hospital, you'd find lots of people involved in the trauma team. So you got the anesthetist managing the airway, and you got the ODB as well.
And the orthopedics too. And
Yeah,
the ODB and orthopedics too.
Yeah, exactly. It's not just the physicians, not just the doctors. So you still got the nurses.
The nurses and the ODB. Okay.
Yeah. So, for example, if the anesthetist would have ODB with them, okay, you may got the ITU team as well, okay, and in ED you would have different nurses, a nurse who normally document all the events that happen in the trauma during the trauma resuscitation or the trauma scenario, nurses who are assigned to give blood and fluids, and nurses who can help with interventions, and you got, as you said, the orthopedic team, maybe the SHO and registrar.
Yes, maybe the radiologist in case I needed an X-ray.
Yeah, the radiographer. Yeah, exactly. So it's so just try to familiarize yourself with the trauma team members in your hospital. Okay.
I thought you were asking about doctors, so that's why I said.
No, that's fine. Just a generic question. Is that like when you asked about what are the team members of your colorectal MDT or upper GI MDT?
Okay.
Patient arrives and you take handover from the paramedics. What history do you want to ask or know from them?
Okay, so I would ask them about the details of the patient, if they did know about his medical history from him, about the incident, how did it happen, if they knew how it happened, how did they find the patient, was he lying on his back, and how was he lying when they found him, how was the mood of the trauma, if they knew about how the trauma happened or how he has been stabbed, and what is the incidents that happened at that time. I will ask them about his vitals when they started seeing the patients. What was his blood pressure? What was his pulse? Did they make a compression? Did they make any intervention? Did they have to give him any medication to support his blood pressure and to make him stable? Or any interventions they did, like compression dressing to stop bleeding from anywhere? And I would ask about the wounds they have seen by themselves, and if they take a picture before closing the wounds. And that mostly.
Okay, so fine. So as you know, there is so it's a hemodynamic and a stable patient, as I said. So it's so you need to take a relevant focused history, and if you look at the ATLS manual, I think you got the ample history. This is the main history that you need to take from the patient with the patient, right? But with the paramedics, as you mentioned, so the mechanism of injury is the most important. Okay, what type of interventions they did, and if the patient is hemodynamically stable or not. Okay. Right. So they tell you patient is involved in a fight and was stabbed multiple times with a knife. Patient's top clothes were soaked with blood, and there was a small amount of blood on the floor. Was no significant external bleeding noted. They noted one stab wound in the anterior lower chest, and one stab wound in the right upper quadrant, and another stab wound in the right side of the chest. And they think the knife that was used is about 10 to 12 centimeter length. They tell you that the patient is shocked with blood pressure of 70/40. He's confused. They placed one IV access, give him 1 liter of Hartmann so far. The patient has a patent airway and got an oxygen saturation of 90% on 5 liters of oxygen. So how you are going to proceed from here?
Okay, so I'm going to assess this patient according to the ATLS pathway. So I will assess his airway, make sure that airway is patent, if the patient is speaking freely or not.
So remember, you are the trauma team leader.
Okay,
so you need to assign rules because you assemble the trauma team, so you need to assign rules to the teams that you have.
Okay, so in this case, I would make sure that the patient had to wipe poor cannula, had group and save in place, has been given IV fluids, has an oxygen supplement in place, and then I will ask one of the doctors to do an ATLS ABCD to make sure that his airway is patent or not, to do the breathing, and to check for any diminished air entry on both sides or on the right or the left side, and to check for his SATs, and also to check for his circulation and his blood pressure, and then take it from there.
Okay, so you see that the patient is hemodynamical and stable. There are no signs of external bleeding. So you think there may be significant internal bleeding, and you want to look at the stab wound locations. So it's isolated stab injury to the torso.
Okay.
So one in the anterior chest, one on the right side of the chest, and one in the right upper quadrant.
Okay. So the problem. So the issue with the stab wounds, it's about that it's usually a small sized wounds, but how deep it goes, that's the problem. So it's about the depth. So if the patient is not maintaining his SATs and he's needing saturation and his blood pressure is low, so I would think about hemothorax, and I would think he's having a stab wound at the chest, so maybe he's having hemothorax. He did have a stab wound at the right upper quadrant. Maybe there's a liver laceration. That would be my thinking at the time.
Yes, this is what you think about. So what you are going to do about it? So now you got a trauma patient who is hemodynamical and stable.
Okay, so what I'm going to do is, as I said, we are going to have 2 wide pool cannula, maintain his saturation. If it's not maintaining, I would do not a needle decompression. I would put a chested drain. And
yeah. So, but again, remember, so you got a trauma patient who is hemodynamically stable, and you think he may got internal bleeding. So you think about he may need massive transfusion.
Massive blood transfusion protocol. I just say group and save for him, but yeah, I would call for a massive blood transfusion protocol for him, and then I will ask for a chest X-ray.
Fine. So in this context, we'll be asked about what is the massive transfusion protocol in your hospital.
I'm not quite sure about this.
Yeah, so it's very important to know. So because in this context, we'll be asked what is the definition of massive transfusion. Okay, and you will get asked what is the massive transfusion protocol in your hospital.
Okay.
Okay, so you need to be aware of that. Okay, it differs from a hospital to hospital. Okay, for example, some people would say, okay, we got 6 bags of FFB and 6 bags of RBCs that we transfuse to the patient when the patient has been released and given to the patient. Okay, and some people would have different protocol, maybe 4 and 4, and maybe 2 platelets, what they call them, 2 balls of platelets. Okay, so you need to be familiar with the massive transfusion protocol in your hospital.
Okay.
Okay, and sometimes if you got a patient who's hemodynamically unstable and you don't have blood that is immediately available, you may need to give them O negative blood.
O negative. Yeah.
And in these patients with severe trauma, you need to be aware of what's called the lethal triad in trauma, which is a combination of hypothermia, coagulopathy, okay, and acidosis. Okay, and this is why you need to give the patient warmed blood. And in most units, you would have an infuser, a blood infuser, which is already with a warmer associated with the infuser. So the blood will just be infused through a warming device, which warms the blood on its way down to the patient. Okay, so you done the primary survey briefly. You obtained IV access. You activated the massive transfusion protocol. You transfuse the patient. You give the patient 2 units of O negative blood because you think the patient is bleeding. And most importantly, you examined the stab wounds. You identified where they are. So you think this anterior stab wound may have gone into the heart. So I will just show you the examination findings now. So this is what you, sorry, just it's not showing up. Okay, this is what you see on examining the patient neck.
Okay. So it looks like engorged neck veins. That means that most probably there is a cardiac tamponade, which is showing may show Pexitrad, which engorged neck veins and muffled heart sounds and low blood pressure. So mostly this patient has cardiac tamponade.
Fine. So and this is the next image when you look at the stab wound in the middle of the chest.
Okay.
Okay, and this is the chest X-ray.
Okay. So I can see there is a pneumothorax on the left side, on the right side, sorry.
Yeah.
And there is on the right side there is a pneumothorax, and with yeah, there is only pneumothorax, and is there deviation of trachea? Just pneumothorax on the right side.
Yeah.
Okay.
Fine. So you got the patient with distended neck veins who got a stab wound to the anterior chest, which may have gone into his heart, and you got a stab wound to the right chest, which may have caused a pneumothorax.
Okay.
Okay, so one of the A&E doctors did fast scan, and this is the pericardial window.
Okay. Right atrium.
So you can see this. Yeah,
This
there's
is
some effusion there.
around the heart.
Yes. So it confirms your suspicion of possibility of cardiac tamponade.
Okay.
Okay, so what we are going to do next? So the patient is still hemodynamically unstable.
In this case, we usually do precardiocentesis, but I never did it. So actually takes the load around the heart to take the blood from around the heart. And also he did have an pneumothorax in which you will insert a chest drain on the right side to decompress the air and make him breathing better.
Okay, so what takes priority here? So if you remember, when the patient came in, he had a saturation of 90% on 5 liters of oxygen.
Okay, so what will take the priority is
what takes priority? The cardiac tamponade or the pneumothorax?
No, the cardiac tamponade. His saturation is 90, and he's maintaining over 5 liters, but he's still hypotensive, and it's the blood around the heart make it difficult to maintain his blood pressure and maintain.
Okay. Fine. So it's also if you don't have time to do the chest tube insertion, you may simply do a sort
intercostal needle in the second intercostal space.
No, this is no longer is recommended. So with the new guidances, you no longer do thoracocentesis, needle thoracocentesis. The new recommendation now is to do a thoracostomy, like you do through the incisions that you're going to use for the intercostal tube. You just do an open thoracic wound, thoracostomy. So I'm sorry, I'm not saying I'm not sure if I'm saying it correctly. Just basically you make a hole in the chest. Okay, if you, but the standard of care, of course, is to put a chest tube. Okay, but because what takes priority is a cardiac tamponade. And the problem with cardiac tamponade is how much it takes, how volume of blood it takes around the heart to start to compromise the heart. How much volume? It's about 50 ml. Can you hear me well?
Yes, sorry, the line went down. Sorry. Yes, I can hear you now.
Okay, so how much blood volume it takes to accumulate around the heart to start giving clinical effect of cardiac tamponade?
I think maybe 150 mils. I don't know.
Yes, it's about 50 ml. So about 50 ml. Then between if you reach 150 ml, at 150 ml, you will develop, a patient will develop cardiac arrest. Okay. So this is why it's important to try to sort out the cardiac tamponade as much as possible, because this is and this situation is ideal for a scenario where you get a young patient with a stab wound to the heart, and they would have enough cardiac tamponade to cause cardiac arrest. Okay.
Yes.
So now you think about pericardiocentesis. It's a problem with pericardiocentesis. It's not very successful, and because it's you do it blindly, it's difficult to know if you actually relieving the cardiac tamponade or causing cardiac tamponade.
Okay.
So it's the recommendation now about pericardiocentesis is a little bit, I think, starting to sway people away from it. Okay, so while you are preparing for pericardiocentesis, if you are going to pericardiocentesis, so the patient's arrests. So what do you think would be the management now? So you got a young patient with a penetrating injury to the heart, with cardiac tamponade, okay, and they develop cardiac arrest in front of you.
So it is, as written, it will be the emergency resuscitation thoracotomy. I did read about it during the FRCS part 1, but never saw it, never did it. So
yeah, okay. Fair enough.
So
Yeah,
that's
so
open.
this is the treatment. So for these patients, this is the ideal patient where an emergency resuscitative thoracotomy is indicated.
Yes.
It is basically in this patient. So a young patient with a penetrating injury to the heart, with a witnessed cardiac arrest. So in front of you.
Yes, that was the indication for it.
Okay. So what are the other indications for emergency resuscitative thoracotomy?
I think, as you said, the witnessed arrest and trauma.
So would you consider it in a patient who's coming to the hospital with unwitnessed cardiac arrest with penetrating injury?
I think there was a time frame for it. I think it was the difference was in the time frame between witnessed and unwitnessed.
So
I think one was 10 minutes and the other was 15 minutes.
Yes. So unwitnessed is difficult to know when the patient arrests. So it's difficult to judge that, and it's it may be the patient's already dead. There are some indications for blunt cardiac injury, but the success from emergency resuscitative thoracotomy for blunt cardiac injury is not as good as for penetrating injury. So it's why the indication in blunt cardiac injury is less limited. So it's if you got a patient who's witnessed arrest in front of you, or the patient who you know for sure that the arrest is less than 5 minutes.
Okay.
And you still, with patients with penetrating cardiac injury, you still would have a successful outcome from resuscitative thoracotomy if you manage to do the thoracotomy and relieve the cardiac tamponade within 15 minutes from cardiac arrest. So you got 15 minutes window. Okay.
15 minutes window to, yeah.
From the time the patient arrests. Fine. So this is the equipment that you need for a resuscitative thoracotomy, and I think you just be aware of them. Whether you are going to get asked about resuscitative thoracotomy in the exam or not, it's not one of the very high yield questions, but it's very important for you to know because it is in the curriculum. So you need to be aware of it, and you need to be aware what instruments that you need to use for the resuscitative thoracotomy. And if you look at any emergency department, they would have an emergency thoracotomy tray in the ED. So next time you go for a trauma call or something, just have a look at it and ask them, what do you have in your thoracotomy tray? And ideally, they should have some sterile drapes, some towels, like scalpel scissors, and rib spreader, which is a retractor, rib retractor. Okay, so this is how you do the emergency resuscitative thoracotomy. So you just do a left lateral thoracotomy at the fourth intercostal space, just underneath the nipple in a male patient, or underneath the mammary fold in a female patient. Okay, and then once you make the skin incision, you make an incision through the intercostal muscles, and you get access to the chest cavity, and then you put the rib retractor, the rib spreader, and you spread the ribs, and you get immediate access to the heart. There is a very good video on YouTube about resuscitative thoracotomy. If you give me a minute, I will show it to you. I think it will be much better to see it rather than I describe what you do. And if you go on YouTube and search for resuscitative thoracotomy, you'll find lots of videos on resuscitative thoracotomy. And we'll speak about this in details as well when we do the trauma lecture. Okay, if I can find the video. Sorry, guys, I'm just trying to find the video for you. Yeah, sorry, I can't find it at the moment, but you'll find it on YouTube. So if you search for resuscitative thoracotomy in YouTube, I think you'll find it. Okay. And also, if you look at the cardiac window, can you see the screen?
Which?
Okay, just a second. So this is the cardiac window. This is where if you got any stab wound to this square where the heart lies in, okay, you would expect maybe cardiac injury. Okay.
Yeah.
Okay. Sorry, just my computer is playing a little bit. I don't know what's going on. Okay, I think I will stop sharing this scenario now, and if you are happy, you can go for another scenario, or we can call it off. It's totally up to you.
Yeah, we can go to another scenario. This one, the emergency resuscitative thoracotomy, I never did it, so
yeah, I know, and I know, but it's in the curriculum, so it's you will be surprised what will come, what will be in the curriculum, and you will see in the exam.
Yeah, that's fine. If we can go to another one, please.
Okay, sorry,
I just have a question. So when I did say precardiocentesis, is it like very wrong to say, and then I had to go straight forward to do an emergency thoracotomy, or
okay, Kawhi-san, it's difficult to answer this question because it's still in the ATLS is
shall
still.
I, like, I would stabilize the patient? I know the patient is unstable, but I'm not.
Sorry, I couldn't hear you. Sorry, I couldn't hear you. Sorry, what did you say last?
Hello? Yeah. So what I'm saying is I'm not a cardiothoracic surgeon. So in this situation, when they give me a case like this, shall I say I need to discuss with cardiothoracic surgeons, or just I would say, and
The question would be,
I would say I would go for thoracotomy.
do you think the patient have time until you discuss with a cardiothoracic surgeon?
No, he doesn't have time, but also if I'm not expert in doing pericardiocentesis and doing emergency thoracotomy, so what is the point? And that's how I ask for the question.
No,
I'm just asking for myself for the exam. So will it be unsafe surgeon if I said, like, I'll do emergency thoracotomy, so I don't know how to do it? Or is it safer to say I will discuss first and then go from there?
No, in an examination scenario, if you think the patient would need an emergency thoracotomy, you say this is what the patient is going to need. If you don't know how to do anesthetic thoracotomy, then you may say, okay, it's fine. I will see if any one of the team, maybe any consultant, are trained to do anesthetic thoracotomy. But ideally, you wouldn't be required to do anesthetic thoracotomy if you don't work in a trauma center. So most people who work in a trauma center are very familiar with doing the resistive thoracotomy, and they do it all the time. And if you do the definitive surgical trauma skills course, so you'd have training session on resuscitative thoracotomy.
Okay.
Sorry, I think there's a problem with my computer. Sorry, I will just log off and log in again.
Okay.
Hey guys, can you hear me now?
Yes.
Yes, sir.
Okay, sorry, just fine. I think it was 12 who wants to go for another scenario.
Yes. If you're happy with this.
Sorry, just give me a second. I think.
Okay, guys. Anyone else wants to go for a scenario?
I'm interested if no one is interested.
Okay. It's Ahmed again.
Ahmed?
Is this Ahmed? Sorry.
Yeah. I did one before, so if anyone is interested, I don't mind.
Yes, fine. Let's go for. Okay, let's find. So you are Aberjai Ahmed, are you?
Yeah.
Okay, fine. I think we can do this fund duplication case. I'll just share it for you. Okay, can you see it?
Yeah, I can see.
Okay, fine. So you got this 45-year-old male patient on whom you performed an SM fund duplication 1 year ago, and the patient is now complaining of increasing dysphagia, and you are seeing him in clinic. Okay, so how are you going to approach him?
First of all, I'll ask about the symptoms, since it's in a clinic, so it's not an emergency situation. I'll ask about his symptoms starting before the procedure, then after the procedure, if it's been relieved completely or not, and then we'll see when the symptoms started to appear. And what do we mean by symptoms started to appear? Is it for liquid, for solid and liquid, most of the time, part of the time, overnight, in the morning? So about all of these things, and then asking about generalized symptoms, including weight loss, vomiting, regurgitation, heartburn, and epigastric pain.
Okay.
Yeah.
Yeah, fine. So he told you that this dysphagia started immediately after the procedure, improved slightly afterwards, but recurred again over the last 3 months, and it's almost now to the point that he's not able to swallow liquids. And he tells you also that he had lots of nausea and heaving for a few days after his initial operation. Felt at some point that something bobbed inside him. This is the history. Examination is normal. His bloods are normal. So you have looked at his pre-operative investigations, and you looked at everything that you didn't see anything in particular that interested you. So any new investigations?
So this is quite an interesting case that it might need a barium swallow plus endoscopy, upper GI endoscopy, to look for the RAP migration,
Okay.
and for any risk of peptic ulcer strictures. For esophagitis or any esophageal stricture.
Okay, so you mentioned possibility of RAB migration. Is there any possibility, anything else that you think may be causing his dysphagia?
As I said, esophagitis, RAB migration, stricture, Recurrence of hernia, which which is the
Okay.
most worrisome scenario.
Okay, fine. So do you think if you, like, for example, if you do a tight wrap, would this cause him some dysphagia?
Yes.
Okay, fine. You mentioned you're going to do a barium swallow and meal. Okay, this is what you see on the barium swallow.
I can't see any.
So I think this is yeah. Sorry, I haven't. Oh, sorry. Since I'm not sharing the right one. Okay.
Yeah.
Sorry, give me a second.
Yeah, this one.
Yeah, this one.
Yeah.
Yeah, so I know it's not very clear, but yeah, you can see some few things in there.
Well, it's I think it's the part of the stomach is above the chest, above the diaphragm.
Yeah.
So it's definitely recurrence of hernia with rap migration, I believe.
Okay, so you can see that the diaphragm is there.
Yeah.
And this part of the stomach is above the
Yeah.
hiatus, above the diaphragm.
Yes. Yeah.
Okay, and it seems that the rab is here as well. So it seems that the rab has slipped,
Yes.
and part of the stomach has migrated up in the chest.
Migrated up. Yeah. It's really very high up migration.
Yeah. So if you the same. So this is the diaphragm. This is green line. It's the diaphragm.
Yeah.
And you can see this is the part of the stomach that has migrated above the diaphragm.
Yeah.
And this is
small hole, yeah.
where is the rab has slipped down over the stomach. Okay, fine. You got a distally migrated fundoplication. So the rab has migrated down over the body of the stomach with herniation of the proximal stomach through the fundoplication, causing some kind of obstruction of the pouch above it, with recurrence of the hiatus hernia. Okay, and this is what you see in endoscopy. So this is the stomach pouch when you go in on the endoscopy. This is the stomach pouch that you see. And when you do a retroflexion, you can see the rab
It's tight.
Yes, just because it's that, yeah.
Around the stomach, yeah. Tight around the stomach.
Around the stomach.
Yeah.
And this is like, if you draw it, this is what looks like. It's like this part of the stomach. So the rab has slid down, and part of the stomach has migrated up.
Yeah.
Above the diaphragm. Okay, so in this context, what, like, because you are upper GI, so likely you get asked about what are the types of fundoplication failures.
I didn't study this before, but for as a common sense, it's either a loose sutures or loose fundoplication that might cause rab failure, or a tight one that might cause rab migration, or a stitch in the esophageal wall to the point that it will cause fistula. But I'm not quite sure about my answer.
Yeah, yes, fine. I think it's if you're doing it in upper GI, if you're an upper GI examinee, so you just need to read it. So you need to know the types of fundoplication failures, how you can identify them in radiology and on endoscopy.
Just so you don't know exactly which is which for the first one, what we call it, because I can't.
So this one, you mean
type A? Type A. What do we have to Yeah. All right. I'm trying to imagine which type A mean.
No, I think just they maybe. I think there are different classifications, but the point is just you need to know them and know one classification and see and how you identify it. But as you mentioned, mostly it's either the rab has completely failed, or the rab has migrated. So you got either completely loose rab,
yeah,
okay, or migrated rab, or partially disrupted rab, or migrated rab. The rab is migrated above the hiatus with complete disruption, with complete recurrence with fundoplication, sorry, of the hiatus hernia, and then you got rab, which is slipped, slipped rab, which is slipped over the gastric body, and with recurrence of hiatus hernia, and you find the crura of the stomach, sorry, the crura of the diaphragm just breaching over the stomach.
Yes, yeah.
Okay, or you got a recurrence of the hiatus hernia with herniation, with paraesophageal hernia. So you got herniation of part of the stomach alongside the esophagus.
I can't see that in the endoscopy. It's clearly.
Okay, fine. So how you are going to manage this patient now?
This is just the only need redo fundoplication.
Okay,
Can't be treated medically or endoscopically.
fine. So have you done a redo fundoplication?
I've seen it once. Assisted my consultant once, but it's quite difficult.
Yeah, of course, yes. Just because this is again in the context of the exam, this is what they're going to ask you. So they will ask you what you're going to do for this patient. You would say the patient needs a redo fundoplication. Are you going to do it? This is the next question. So if you've done it,
I think it's need to be referred to specialized upper GI surgeon. I mean, specialized upper GI center with an expert in redo.
Yeah, right. So it's basically depends on your expertise. So if you've done it, that's fine. You can say I've done it and you discuss it with them because they will ask you about it. If you haven't done it, just clearly you say what you do. Okay. Yeah, fair enough. I think yeah, fine. I think this is the main point from this scenario. Just identify types of fundoplication failures and discuss redo fundoplications.
Yeah. All right. Okay.
Okay. Fine. Okay. Okay, guys. Thank you very much, guys. Do you have any questions?
Just a quick question, not in terms of scenarios, in terms of library. Would we be able to gather the guideline, the most updated guideline, and put in the library? Because keep asking about which part of the WS World Society of Emergency General Surgery or for upper GI guidelines. So
yeah, I think for the guidelines, I think it's very important that you are aware of all the guidelines in your specialty and in the general and emergency surgery. And unfortunately, I cannot answer any question about the library because I think Manny manages the library. But if you if you put the question on the Telegram group, I think Manny will be able to give you an idea if it's possible or not. I think it's possible to do if you want us to post the all the guidelines on the library, but the reason I'm saying that if you kindly put it in the group is just because I don't promise that I'm going to put it because it's a lot of work to do. So but I think I don't know if we already put it in the library, maybe already there.
I've seen part of the guideline, like for the pheochromocytoma, there is a guideline that put it there, but I mean, especially for colorectal and general emergency, these are things that we would definitely upper GI. That's part of that I need, and I'm struggling to find the guideline because there's no actual guideline apart from some OGS guideline. But that's fine. I will send it to.
Yes, I got a collection of guidelines that I've summarized for my exam. So I'm happy to put these on the library. They may be a bit helpful. But I'm not sure what guidelines are already there. And if it is possible that we are able to put the rest of the guidelines. But most of the time, what we do, we publish these guidelines or put them in the Telegram group. So while we are going through the course, so you will notice that we put some new guidelines all the time on the Telegram group. And I think by the end of the course, you may find most of the guidelines are already there.
Yeah. Thanks, Mohammed.
Okay.
Can I ask a question, please?
Of course, yeah.
So I'm not aware about the Telegram group. How can I join the group, or how can we find it?
So have you registered for the course?
No, I just this is the trial course, the trial sessions, but I didn't register to the actual course yet.
Yes, fine. So because I think the candidates who registered for the course, I think that these are the ones who joined the Telegram group. Because the Telegram group is for the course candidates.
Okay, thank you. Another question: the script that you are using for the scenarios and the questions, we have access to such script or such scenarios?
Yeah. No, normally no, they are not on the library, and normally we don't give them to the candidates because we use these and the modification of these for different courses.
Okay.
So these scenarios I prepared myself. I prepared them from actual real cases. See, these actual real cases that I've seen.
Yeah. Thank you.
But it's but most of the Viva cases, we normally don't give access to the candidates to see these cases. But over the course, what you can just write down the scenarios if you want, and we'll give you all the questions like what I've written here. Just this is what you need to know. This is what's important for the exam. You need to be aware of that. And if you write this down during the course, you'll be able to get most of the scenarios with you.
Yeah, thank you.
Okay, guys. Can I help you with anything?
Thanks, Mohammed.
Okay.
And is there a deadline for the registration for the actual course?
To be honest, I'm not sure, but I don't think there is a deadline for the course registration. But you can double check with Manny. Do you know the course website?
Yes, I think I have the link or the
Yes, if you go on the course website, I think you'll be able to register for the course. But I don't think there is any deadline.
Yeah, thank you.
Because the course is over 3 months, so even if you register late, maybe a week or two, I would expect you to be able to find a space. It depends on space availability.
Yes, thank you.
Okay, guys, thank you very much for your time. I hope you enjoyed the session. Okay, and have a nice evening, all of you.
Thank you.
Thank you, Mohammed. Bye.
Yeah, thank you
Thank you
guys.
so much. Thank you.
Thank you.